Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
When we talk about surgical excellence, the public often has this idea that there's a moment, a single point where competence is just, achieved.
Like a light switch. You do enough cases and suddenly you're an expert.
Exactly.
Hey.
But anyone who's ever stood across an operating table knows that's just, well, it's not reality. Surgical competence isn't a switch. It's a long, really structured learning path.
It absolutely is. And for you, our listener, whether you're a surgical professional in training or, a senior doctor training others, the whole point of this deep dive is to get past the anecdotes.
Right.
We've dug into the research, the systematic reviews to try and provide a realistic, evidence-based roadmap for what competency looks like across common general surgical procedures.
And to really emphasize that true refinement, it happens over years, not just a few months.
Mm-hmm.
Now, before we get into the actual numbers and the curves, we have to state the obvious but essential clinical rule.
Oh, absolutely. This is critical. This content is for reference and educational purposes only. It's about providing context from the literature.
It's not a replacement for your local training.
Not at all. You must always, always adhere to your local guidelines, your institutional protocols, and specific clinical practices. This is context, not curriculum.
Okay, with that said, let's unpack this. The core finding, really, is that competence builds over tens of cases, and it's supported by structured supervision, simulation.
And that quality of supervision, that often matters so much more than just a raw number of cases you've logged.
That is such a vital distinction. So how do we talk about this? Is there a common language or framework?
There is, and it's useful to think of the operative learning process in 3 distinct phases. It helps track progress in a more objective way.
Okay, so what's the first one?
Phase 1 is the initial safety phase. This is the absolute baseline. The goal here is just to complete the operation reliably.
Without a major complication or having to convert to an open procedure?
Exactly. It's slow. It's methodical. It's all about developing the muscle memory for a safe sequence under constant, close supervision.
So just getting the job done safely, even if it takes, twice as long as the consultant.
Precisely. Safety over speed, every time. Then you move into the second phase, which is the proficiency phase.
This is where things start to click.
This is where the training starts to pay off. Operating time begins to drop. Key outcomes like minor complications, length of stay, they start to look a lot like those of an experienced surgeon.
But, and this is a big but, I'm guessing.
A huge but. This is typically only for the straightforward cases, not the complex ones.
And the third phase is that long tail of just continuous improvement.
That's the mastery and efficiency phase. And this can stretch for years into independent practice. This is where you're handling true complexity redo surgery, weird anatomy, managing complications flawlessly. For a trainee, the focus is really on getting through phase 1 and 2 safely.
This is where it gets fascinating, right? Connecting these phases to the actual operations we do every day, we have to start with the most studied one, laparoscopic cholecystectomy, LC.
It's the gold standard for studying this stuff. And when we look at the literature for that initial safety, just getting technically competent, the range is pretty wide.
How wide are we talking?
Well, modern studies using objective metrics like CUSU analysis, they suggest a tighter range. Maybe 7 to 25 cases?
Okay, hang on. Why CUSUM specifically? For someone who just does a basic audit, what does that tell you?
CUSUM is it's a game changer because it tracks performance sequentially. It graphically shows you the exact point where a trainee's performance stops declining and it stabilizes.
So it's a mathematical signal that they've got the basics down.
Exactly. It's an objective marker for completing phase 1 rather than just a supervisor's gut feeling.
Yeah, it makes a lot of sense because some of those older reviews quote these massive numbers, right? Like 13 to 200 cases.
They do, and that heterogeneity is scary, but it reflects, a couple things. First, the case mix. Are we talking a healthy patient or an emergency inflamed gallbladder? And second, the definition of competency.
They were mixing up proficiency with basic safety.
They were. When you use structured training and control the case mix, that curve gets a lot shorter and steeper.
So let's talk about phase 2 proficiency, which is so often just measured by operating time. The data I've seen suggests time drops really fast in the first 20 cases.
It does, but then it continues to fall just much more slowly. It often only really plateaus after around 50 to 60 LCs.
And at that 50 to 60 case mark, a supervised trainee's outcomes can actually match a consultant's.
In basic, straightforward cases, yes. The complication rates, length of stay,
Yeah.
they're often comparable. The trainee is safe. but their theater time is almost always still longer. That efficiency gap is the last thing to close.
So if you're a brand new trainee, what are the realistic milestones you should be aiming for in those first few attempts?
First 10 to 15 cases. It's all about the fundamentals. Safe access, setup, retraction, and really achieving the components of the critical view of safety under constant direct guidance.
You're just learning to navigate the Calit triangle safely.
That's the entire game. Then, once you get into that 20 to 30 case range,
Yeah.
that's when you should be performing most of the steps yourself, recognizing your limits and knowing exactly when to ask for help before something goes wrong.
And then beyond that 50 or 60 mark, as a senior trainee, that's where judgment really comes in.
Absolutely. Consolidating efficiency, yes. But more importantly, handling moderate difficulty obesity, some inflammation, and knowing when to use bailout strategies, like a subtotal cholecystectomy, instead of pushing through a dangerous dissection.
Let's switch gears to the emergency side. Appendicectomy. This is usually the first big one a trainee does as the primary surgeon.
It is. And for laparoscopic appendicectomy, or LA, the learning curve is often about the technical skills of laparoscopy itself, not just the appendicitis.
So what do the numbers say?
The guidance, including from the EES, suggests around 20 cases is a minimum for reasonable proficiency. The operative time and complication rates tend to stabilize around that 20 to 30 case mark.
So about 20 cases, which is actually pretty similar to the LC curve because they both rely on that general laparoscopic skill set.
That's a big part of it. Now, open appendicectomy is a different story.
Shorter curve.
Much shorter. The technical steps are just more direct. So trainees generally get comfortable with straightforward open cases after maybe 10 to 20 supervised operations.
And in those early cases, what's the focus? What should you be drilling into your routine?
For LA, it's all about meticulous camera work, secure stump closure, and, crucially, recognizing and managing infection. For open, it's sound incision technique and secure ligation. Just fundamental, safe surgery.
Okay, for our third case study, let's tackle a big one. Inguinal hernia repair, and specifically the TEP repair, which has a reputation for being pretty unforgiving.
Yes, the total extraperitoneal repair is a real challenge. You're operating in a space you have to create, the preperitoneal space. It's technically demanding.
So what are the numbers for TEP? How do we separate just getting the operation done from achieving those really good long-term outcomes like low recurrence?
That distinction is everything. The immediate safety phase, just avoiding conversion to open, is probably achieved after at least 20 TEP repair. Okay.
But overcoming the main learning curve in terms of complications like hematomas or nerve injury and stabilizing your time, that often requires more like 37 to 40 cases, maybe even more.
Wow, so that's a big jump. 20 for basic safety, 40 for stable performance. What about true mastery?
For mastery, low recurrence rates, handling complex or bilateral hernias efficiently, some studies report numbers from 100 all the way up to 250 cases.
So phase 3, the mastery phase, really does extend way beyond formal residency.
For this procedure, absolutely.
And how does TAPP compare? Is it any easier?
Generally, the TAPP, the transabdominal approach, is seen as having a slightly shorter, more forgiving curve. You're working in the familiar peritoneal cavity, so orientation is easier.
And open Liechtenstein.
Much more like the open appendicectomy model. A much shorter curve, maybe 15 to 25 supervised cases to get the bulk of the procedure down safely.
So a trainee's progression really starts with assisting, understanding the anatomy, then moving to straightforward primary repairs in that 20 to 40 case range for the endoscopic stuff. Exactly, and the supervisor is just laser focused on preventing those key early errors.
We spent a lot of time on how many. Let's shift the focus now to how. The principles that can actually shorten this learning curve, no matter what the operation is.
This is where quality of training just completely overrides quantity. And first on the list is deliberate practice.
So not just doing the case, but learning from it.
Right. It's treating every single operation as a chance for structured improvement, using targeted feedback, video review, even checklists against structured tools like GoalLS.
So what does that look like? If I've done my 30th LC, how do I apply that?
You look at your GoalLS score. Maybe it shows your instrument handling is inefficient. So you review the video of your last case, focusing only on that, and you practice that specific action in your next case, asking for feedback on just that. It's targeted. It shortens the unsafe part of the curve.
And that leads right into the next point, which is simulation.
Yes. Box trainers are essential for dexterity, but we're increasingly using procedure-specific simulation. If you can practice the tricky steps, like getting the critical view in a simulated environment.
Your first live case is going to be safer and faster.
Exactly. You move the steepest part of the curve out of the operating room entirely.
And the third principle is graduated autonomy.
This is just putting phase 1 and 2 into practice. You progress step by step. You start as the camera operator, then you do discrete parts of the procedure, and only then do you move to the whole thing in a low complexity case.
You map the responsibility to proven ability.
You have to. And finally, and this is non-negotiable, is careful case selection.
Protecting the patient and the trainee.
For early practice, it has to be the lowest risk cases. ASA 1 or 2, non-obese, minimal inflammation. And the senior surgeon must be present, scrubbed, until that trainee's performance is clearly stable.
That brings us to our final takeaway for you, the listener. The true learning curve is, of course, individual.
It is. It's influenced by aptitude, your case mix, institutional volume, but the research gives us these objective boundaries, a realistic expectation.
For a new trainee, achieving that basic, safe, technical competence in straightforward cases. It's going to take the first few dozen supervised attempts of each procedure.
But we have to be honest. Full proficiency, efficiency, handling complexity that requires sustained, deliberate practice and high-quality mentorship throughout all of higher training, well past the point where you're technically allowed to practice independently.
So given that reality, here's a final provocative thought for you to consider.
How should our hospitals and our training institutions better structure post-residency mentorship? Not just during training, but after. How do we ensure there's ongoing critical feedback to keep reducing complication rates for those complex cases that only really show up later in a surgeon's practice?
Something important to mull over. If you found this deep dive useful, please do not forget to share it with at least one of your colleagues or friends to spread the word. Also, check out our YouTube channel and other social media pages for more in-depth analyses. We appreciate you joining us for the deep dive.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.